Hi, I'm Jack West, medical oncologist at Swedish Cancer Institute in Seattle, Washington. One of the questions that comes up not infrequently in the management of lung cancer is how do we best deal with the situation of a mixed response to treatment? So what is a mixed response? Well, we tend to grade the results of our treatment, particularly in the setting of more advanced disease that is measurable on scans, by comparing the results of a scan done before treatment to a scan done after 2 or 3 cycles of therapy. So that's typically about 6 or 8, sometimes as many as 12 weeks of treatment. And you look at the older scan, you look at the new scan, and you see whether the areas that we know are cancer have shrunk, which represents a good response to therapy, or have increased in size, which suggests the cancer has progressed and is resistant to our treatment. But in between, we can also have a couple of results. One is that the cancer doesn't really change size at all, and that's called stable disease. That's really a situation of glass half empty versus glass half full, but in the setting of lung cancer, particularly more advanced lung cancer, we tend to be pretty happy to see stable disease because that is a form of disease control. The cancer would otherwise be growing if it weren't on treatment. And stable disease tends to be associated with prolonging survival as well. But there's also the situation of a mixed response, which is that when we compare the new scan to the one before the treatment, some of the lesions have shrunk in size, but others have actually grown. Or there are a bunch of lesions that have reduced in size, but there's 1 or 2 new spots. So what do we make of this? This is a mixed response to treatment. And when we use a formal grading system for clinical trials, the result is basically that you measure all of the so-called measurable lesions on a scorecard, and you tally up the dimensions, and you look really at whether the net result is a little bit of growth or a significant amount of growth or stable overall, or the balance is more in the direction of a shrinkage, of a response. On the other hand, if you see new lesions appear in our formal grading system, that is considered progression of disease. And really, outside of a clinical trial, we tend to do a very similar process, where if the cancer overall looks like it has shrunk in far more places than it has grown, we tend to be pretty happy with that result, and we might want to continue that therapy. On the other hand, if there's a little bit of shrinkage in an area or two, but overall there are multiple new lesions and a lot of net growth, well, we tend to consider that as probably more valuable to move on to the next treatment. But at the same time, there are a few other modifying factors that I think are very appropriate to consider in clinical decisions outside of a clinical trial. One is, how is the patient tolerating therapy? If there is a mixed result and overall some lesions have shrunk, some have grown a bit perhaps, but the patient is tolerating therapy very well, that would lead me to be far more inclined to recommend continuing on that therapy. On the other hand, if a patient is having a very difficult time tolerating it, I would be less inclined to persist on a therapy where we are seeing some progression. And then another factor that's also important is, what are the alternatives? If a patient has been on chemotherapy and we find out they actually have a driver mutation, like an EGFR mutation that is associated with a high probability of responding to an EGFR inhibitor like Tarceva or Erlotinib, we would be much more inclined to switch to Tarceva very quickly if we see a mixed response on chemotherapy. On the other hand, if a patient does not have good alternatives, if they've been on multiple lines of therapy and there just is nothing else waiting in the wings that is a clear good alternative, the option of staying on a treatment where we're seeing some response and maybe a little bit of progression might lead us to be far more tolerant of a little bit of progression and be inclined to stay on that. So you can see that in real practice, outside of a clinical trial, there's some subtleties and many factors that are involved in how best to manage a mixed response, and that's why it really makes sense to individualize to your particular case. I hope that's helpful. Take care.